My special guests today are Professor Nicola Lautenschlager, who is Chair of Psychiatry of Old Age at the University of Melbourne, and Research Fellow Dr Terence Chong. Thank you both for your time. Give us a few basic facts about dementia in Australia. What's the burden we're facing?
Prevalence is very high. So in 2015 there were 343,000 Australians who were affected, and this is projected to rise to 900,000 in 2050. So that's a significant challenge for our community and for health services and people and their families.
Mm-hmm.
So the cost is also significant, and I think the global estimate of the current cost of dementia is $818 billion.
What's the current treatment focus? What do we use at the moment?
So at the moment, it's a combination of medication, where it's appropriate and indicated, and obviously, ideally, a big support network for the patient, but also for the family. So the current guidelines internationally and also here in Australia suggest if the dementia syndrome is due to Alzheimer's disease, which is the most common cause, and is mild to moderate, so not in the end stages, the recommendation is to try a medication which are called as a chemical class cholinesterase inhibitors.
Yep.
And they are available in Australia via the PBS.
Yep.
And then if they can't be given because of side effects or contraindications, there is a second class of medication which is available. The problem with these medications is none of them are curative.
Yes.
So all they can do is, in the best case scenario, to improve symptoms for a while and to maybe delay the progression, but they are not curative at all. And they have been around now for quite a while, so we're talking, at least 20 years. So there's an urgent need to find something better.
And where is the research focus now? What are the advances that we're hoping to see?
The main focus of activity there and the area where medications have progressed most have been around the amyloid cascade hypothesis. So that's the idea that in Alzheimer's disease there is an abnormal deposition of a protein called amyloid, which is responsible for much of the damage to neurons, which causes the condition. I guess as it's a hypothesis, there are also other hypotheses around, but this is the one that's received the most attention. So the medications that have progressed most in trials would be using vaccines, so antibodies to amyloid. So we mentioned solanezumab and aducanumab in the editorial, which are both antibodies that target amyloid and I guess trying to reverse the deposition of amyloid.
Where are those strategies in terms of trials, getting them from bench to bedside? Where are they at?
Yeah, so I think the one, as far as we could tell, the one that's progressed the most is the solanezumab. So that's actually in the next few years moving to, or being conducted as a large phase 3 trial, which is looking at much larger numbers, and also they're trying to intervene earlier in the stage of the disease as well. So, for example, there's a trial at the moment called the A4 trial, where they're using this antibody in people who have evidence of amyloid deposition but without the cognitive problems as yet.
Why does it take so long for a drug to get to patients in this particular field? I mean, as you said, it's 20 years that these treatments have been in place.
The problem in dementia is that we had, as we wrote in the editorial, an enormous amount of drug trials in the last 20 years with an enormous cost. Most of these trials are now big international trials, and none of the medications, and I think there have been 200 products or something, have reached the patient yet.
Wow!
So that is incredibly frustrating for the families and also treating doctors and clinicians. And there's lots of debate in the research community why that is the case. Why is it so particularly difficult in Alzheimer's disease? And I think especially because we had the relative success of the cholinesterase inhibitors in the 90s. So we thought, oh
Yep.
yeah, great,
Here we
so
go,
we're on the
yeah.
right track. And you know, you hear different views when you go to any of the large international meetings now. One view which was voiced was, well, obviously there must be more than the amyloid hypothesis, otherwise it would work.
Right.
For example, you know, other pathological mechanisms which may be interacting. There are other views which are saying, no, it's still the best hypothesis we have, but it might be the way we conduct these trials.
Okay.
And one thing we mentioned in the editorial is that they might be too late.
Right.
Because Alzheimer's disease develops over many decades in the brain. And basically the clinical symptoms, when they start to be of a magnitude that, you know, someone seeks help, lots of damage has already happened in the brain.
Yeah.
And so now just like in the A4 trial, there is much more a focus on looking at this more preventative, identifying people at risk even before they have expressed symptoms. So that could be a reason, but then there were also concerns, maybe the trial design, how we set up the trials might not be appropriate anymore. So I think now is a phase where people scratch their head and take a step back and think again. And because it's such a prevalent condition, the movement is now that government supports drug company, that we have really international consortia trying to solve this together.
Yeah. If the damage is done before we see symptoms that drive us to our doctor, does that mean we need a national screening program to find people who are at risk and to test them and treat them before those signs come up?
Difficult question, isn't it?
Yes.
I know it's a hot topic, yeah.
It's a very hot topic, and you know, I must point out, none of us, no Terry nor me, are experts in the screening debate. But it is an international hot topic. So, for example, in the United Kingdom, they're a bit further ahead, and they have tried different things, and there's a very hot debate there. As far as I'm aware, there is no evidence at the moment that screening works for dementia on a, let's say, primary care level.
Right.
And if we say works, we have to see that in the health economic context of a society. Just like you have screening programs for breast cancer and so forth, you have to find out, is the money we invest worthwhile, the damage we can prevent?
Yeah.
And that hasn't been shown, to my knowledge, internationally, but also in Australia.
Yeah.
I'm sure there will be ongoing debate. And you know, that's not to say that it's not a good idea that if people have their regular checkup with their doctor, it would be good if they mention they have noticed changes, or if their GP asks, have you noticed any changes regarding your mental health or your cognition?
Yeah. You also mentioned in your editorial that there are delays in diagnosis happening.
I think there are a lot of different factors in the delays to diagnosis, and one of the key factors, I think, is that there can be a degree of reluctance or stigma related or fear related to a diagnosis of dementia, which may mean that people themselves are anxious about asking their doctor about it or talking about it, or they may not be aware of problems that they've had, but perhaps other people around them have been aware of that, and often you have family members who say, I can't convince them to go and see the doctor. There may be also reluctance on the doctor's part to diagnose dementia in somebody they've been looking after since birth, because it's a difficult conversation, it has a lot of consequences. So people have all sorts of fears. For example, they say that if they get the diagnosis, does that mean they'll be put in a nursing home, or does that mean they'll lose their driver's license and lose their independence? So I think that's a big part of why there is a delay in the diagnosis. And I think the other part of it too is as you mentioned, that we think that GPs, and my experience of GPs is that they do a lot of excellent work in terms of diagnosing things. They have to manage everything that comes to their doors, to their doorstep. And like with most things, the challenges in general practice are around resources and time, as we all know, and dementia diagnosis often takes a lot of time, and so it relies on people coming and then also having that time to look at things and assess things. And I would also agree that I think there's always scope for us to improve the education and the resources that are available to support GPs in their important roles through medical schools and through colleges and so forth.
And what about?
I think it would be lovely if we could do much better than we do already, is support for the family and the carers.
Yeah.
So people are often very surprised when I talk about that, how many carers we have in Australia, and that almost every second person who's older age in Australia is caring for someone.
Yes.
And it's growing. And our society would fall over if carers would say tomorrow, I'm not doing it.
Yeah.
So we depend financially on that, and most carers love to do it. They love to look after their carer, but having said that, it is at a significant price.
Yes.
And especially if they're older, it increases their morbidity, it increases their mortality, and around 50% of older carers have significant symptoms of depression. And I think any effort we can do as a society to offer them more support, so that means more research in what carers want and need, but then also translating programs which have shown to work better into the community, that they're accessible for general practitioners to have that on the tip of their hands, that they can inform their patients. I think that's really important. And then in general, translating the little steps we make in learning more about dementia in terms of diagnosis, prevention, intervention, back to the community faster. Very often when I talk about our research, community members come up to me and say, where can I have that? And I have to say, sorry, you can't at the moment. And I know, there are already very good efforts in Australia to invest money into translational research, but I think that will be something else on the top of my list.
Thank you both for your time today.
It's a pleasure. Thank you.